Our next speaker is Vedat Deviren. Vedat is a professor of orthopedic surgery at UCSF and a spinal deformity specialist and good friend.
Okay, today, what's the worst time to give a talk in a conference? It's either before the lunch or after the lunch. So let me see if I can get your attention back, or at least get some attention. So how many people in the room that thinks about the prone to psoas or prone lateral surgery is very skeptical about the surgery? All right, Alekos is very skeptical. Only one? Okay. I was very skeptical, so I think it's totally normal to be skeptical and concerned about the procedure. And usually we are not really open to changes, especially when you're quite a few numbers in practice and you get used to your procedure. So before I talk to the PTP, I'm just going to talk about, in general, the interbody fusion. So I did my fellowship in 2001 at UCSF. I trained with Serena and Dr. Bradford. And we done, it was a very heavy deformity fellowship, and we really believed in circumferential fusion. I know at the time that there is certain training that actually they still believe that the posterior-only procedure is what might be sufficient enough for deformities, but at UCSF, we really believe that circumferential fusion is the way to go. So at the time, we were doing large thoracoabdominal approach, like T10 thoracotomy, resecting the rib. So how many people in the room that have done T10 thoracotomy and thoracolumbar approach? Like really big shark bites. Wow, all right. So those are the people, are old people in the room. Okay, so we don't do that anymore because it becomes at the time we realize that it's such a morbid procedure. Patients have a lot of, surgical morbidity related to approaches. And then we actually, at the time, we were not even doing paramedian anterior ALIF procedures. We were just all doing long, multi-level interbody fusions through the large thoracoabdominal approach. And then we actually moved to do more anterior approaches. And then the company, San Diego developed the lateral approach known as XLIF. And then we start doing the lateral approach. And then the ALIF become another alternative. And then most recently, there is this prone lateral procedures that being proposed. But there are significant benefit of anterior approach. One is that you can put large anterior interbody graft. Surgical time is actually fairly short. Mainly the time is being spent during the exposure. Because of the dissection, you're not really cutting significant muscles. There's definitely less blood loss unless you get into the vascular injuries. And one of the other benefits that we discovered that the indirect decompression. So what are the alternatives now? We have ALIF, lateral interbody fusions, ALIF, and the new transpsoas, prone transpsoas approach or prone lateral surgery. In general, when we do spine surgery, there's basic principles. You want to achieve a good fusion, maximize the alignments, and also decompress nerves directly or indirectly. But the interbody fusion actually provides quite a bit benefit to these procedures, especially when you do it anteriorly. What we learned over time is actually by doing these procedures, we learned a lot of local anatomies, the vessels, and especially the transitional anatomy. I don't think that we were really paying that much attention to the transitional anatomy before we start doing the lateral, because we start seeing significant number of complications when you do this procedure on transitional anatomy, vascular and neurological complications. So we start looking at the MRI, not just neurologically, we start looking at the MRI at the front of the spine, look at the psoas, look at the vessels, look at the lumbar plexus. And you can see that the difference between the normal and the transitional anatomy, it looks like a Mickey Mouse approach. Mickey Mouse, the psoas goes anterior, and then with that translation, actually, the plexus also goes much more anterior. So those patients are not a good candidate to do either oblique or lateral surgeries. So if we, I'm going to go, a little bit more quickly on my slide. So I hope that we can have interactive discussion about the prone lateral or prone transpsoas surgeries. I know there are a lot of questions about the procedures. What is the benefit? And I can share my experience with you. So the ALIF has I think everybody does ALIF in the room unless you don't have an access surgeon. Who doesn't do ALIF? Everybody believes in ALIF. So there's significant benefit of the ALIF. There is no disruption on the posterior elements. There is no nerve retraction is necessary. You can place really large spacers and get really good alignment corrections, and can be performed in open laparoscopically. But most often we use paramedian approach. But the disadvantage basically, there's risk of vascular injuries, especially the experience of the access surgeon becomes really critical. And if you don't have a good access surgeon, it can be a little bit complicated procedure. One of the risks is in young males is retrograde ejaculation. And one of the disadvantages, because of you are resecting the ALL, it requires usually stabilization, and most often requires the pedicle screws. And the lateral interbody fusion, it's actually kind of quite a good alternative way of doing the ALIF, because higher lumbar segments, the ALIF becomes difficult because of the renal, vessels that on your way. It's kind of difficult exposure above L3. So therefore, the lateral, the interbody fusions also is a less invasive procedure that it become popular since 2005, and become really accepted procedures. It's less invasive, patients recover quickly, and there is very minimal risk of cardioquina. The construct, the cage is inertly stable because you are not taking the ALL down, and it's quite a stable construct, and because of the large graft, going from ring apophysis to the other ring apophysis, it's a stable construct. And you can really restore the disc height, and the indirect decompression becomes a very good alternative to your patients. But again, we can also discuss about who are the good candidates for indirect decompression, who are not. And it's more clinical decision, not necessarily radiographic decision. However, there are quite a bit, there are a lot of publications that came out since then, and which been reported that there is a potential risk of bowel injuries, vascular injuries, and you cannot access the L5S1 because of the anatomical structures. You can achieve, sometimes, you may need to do direct decompressions. You may not achieve with the, lateral interbody fusions. And most of these patients are going to require repositioning for the screw placement, and they require prone positioning after the lateral interbody fusion. And some surgeons are not familiar with the approach and the anatomy and require some additional training. And the oblique lumbar interbody fusion actually becomes an alternative because we realize that the lateral interbody fusion has some risk of lumbosacral plexus injuries, and the oblique interbody fusion is being proposed, which you can kind of actually approach the lumbar spine more anteriorly, and doesn't dissect the psoas, and you don't need to go through the psoas muscle. One of the major advantages, since you are approaching much more anteriorly, neuromonitoring may not be necessary on these patients, and also you can access the L5S1 with the ALIF approach. However, the complication of ALIF is more similar to ALIF. There is more sympathetic chain and vascular injuries with the ALIF approach, since you are more anterior, more closer to vascular structures. And because of the oblique approach, the contralateral foramen might be in a danger of violation. You can achieve an indirect decompression. And again, like the lateral interbody fusion, also requires prone positioning for other posterior procedures. And again, the surgeon training and the familiarity is the somewhat difficulty for adaptation of the procedure. So these are actually there are more papers being published in terms of complication of the lateral interbody fusions. We know the risk of bowel injuries, vascular injuries, femoral trunk injuries, and the ALIF approach. There is very limited publications for the ALIF, but if you look at all these publications, complications seems similar to ALIF approach more than the lateral approach. More vascular injuries, less neurological injuries, and more sympathetic nerve injuries. But overall, all these procedures have similar number of complications. Usually it's single-digit complication with these procedures, which is very acceptable. And then most recently, a couple of years ago, surgeons started to try prone transpsoas surgeries or prone lateral surgeries. And I was at the time very skeptical because the first thought that you came in your mind is why am I going to do something that I can do lateral that I need to do prone position? You can do it, similar to less invasive surgery. It does have similar benefits to lateral interbody fusion. And definitely you can get much better segmental correction because just prone positioning the patients, by positioning in that position, gravity pulled the patients down and you can get much more normal, harmonized lordotic correction on these patients. And by just in the prone position, the OR stuff, and you're much more familiar with the prone positioning, and you can do any prone procedure that you require to do at the same time. And most people are more familiar with prone positioning than the lateral. So there are a few publications that coming out because I think more and more surgery has been done. I think overall, somewhere between 3,000 to 4,000 cases being performed. And if you look at the, compared to historical data, seems like the prone lateral position, prone transverse surgeries achieve a little bit more, a little bit better segmental correction than the lateral interbody fusion and the TLIF. And you can see those, just the prone positioning that allows you to get really nice segmental correction. You can see that on this example that the patient in, standing X-ray shows significant collapse in the disc space. Just by positioning, not even doing the surgeries, you can really get these nice lordotic correction. And that actually makes the surgeries totally different. So prone lateral is not doing a lateral procedure in prone position. It's a completely different procedure. And I was doing one of the podcasts, and they asked me, what was the major limitation in me to adapt the technique? And I realized after doing a couple of cases, it was completely the mindset. So I done so many lateral interbody fusions, and one of my to-go procedures was I staged my patients to do the lateral decubitus interbody fusion, and then stage them to the prone position and do the posterior instrumentation and fusion. And I was very comfortable, and I was having really good results with that procedure. So to me, it was very difficult to think about why am I going to change and do the prone position. So with that mindset, that was the main thing that actually limits you to adapt the technology. And then your mindset, if you do a lot of laterals, you are thinking about, okay, I'm going to do the same procedure in prone position. It's actually completely a different procedure. And it seems like the younger surgeons who does not have the experience adapt to prone lateral much faster and much quicker than the older people who are commonly experienced, who had a good experience with the lateral interbody fusion. So one of the major advantages is the sagittal plane alignment. So you can see that, this example, there's one of the good indications is spondylolisthesis. One of the concerns with the lateral interbody fusion, because of the end plates overlapping is significantly slipped, then you are usually concerned about that aligning that segment in the lateral position. But with the prone lateral, actually, a lot of patients that you recognize it by just positioning reduced significantly. All you do is the exposure, preparing the disc space, and putting the interbody spacers. But again, the data is not out there. Most common data is more anecdotal experience. The prone transverse or prone lateral complications are similar to lateral interbody fusion complications. The bowel injuries, the vascular injuries. You cannot access to the L5S1. There is definitely a learning curve. And it took me about 3 to 4 cases to really adapt the technique. And one of the major relative contraindications is the obese patients. Because when you place the patient in lateral decubitus position, obese patients, all the anterior structures goes to the front. So it is much easier to perform the lateral interbody fusion and lateral decubitus position in obese patients. But when patients, especially morbidly obese patients, when you put them on a Jackson table, if the belly doesn't go between the Jackson table, it just goes outside the Jackson table. And then what happens actually, you push everything back to the posteriorly. So, and also the depth of the axis is going to be much more deeper because of all the tissues are being on the side. So it's very difficult to do in obese patients, actually, morbidly obese patients. So I have one case example. So this is a 74-year-old, predominantly back pain, difficulty standing upright, disabled for 4 to 5 years, take hydrocodone daily, patient has osteopenia, and no significant past medical history. So this is a preoperative x-rays. You can see that there is a significant lumbar curve. Before I start adapting the my typical to-go procedure on these patients is the lateral, and then go back, do multi-level lateral interbody fusion, usually L1 to L5, and then go back and do the long segment construct with the 5-month TLIF. After reviewing my, quite a few volume of cases, I realized that some of the patients, even with the 5-month TLIF, they develop pseudoarthrosis, and I start doing the ALIF. So then it becomes like, I'm doing ALIF, positioning patient lateral decubitus, do my interbody fusion, and then going to the back and doing the posterior instrumentation. What has changed after I adapt the technology in prone position is actually I do the ALIF first, 4-to-1, and then as a second stage, the same day, it's not a second day, I position the patient in prone and do my prone lateral, at L2-to-4, and then do my posterior instrumentation fusion, and the entire procedure is usually done in one day. And there are some papers that I think Srina published that, staging the patients sometimes is difficult on certain patients because they're actually, not getting any calories between the stages. So it makes the second stage, the posterior procedure, quite a bit complicated. So these are like all the measurements being done and the alignment plan is being performed. So the first stage was the ALIF, and then the second stage was the, prone position, prone lateral cages, and the instrumentation. So these are the post-op images. So in terms of key points, in terms of anterior approach, anterior interbody fusions, they all great procedures. The ALIF, lateral, the OLIF. They are powerful techniques to achieve, arthrodesis, and allows you to deliver large interbody grafts. I really do not prefer TLIF actually, because I think it's a great procedure, but I think you will achieve much better results with the larger bone graft with the anterior column approaches. ALIF is the safest at the L5-S1 interbody space, but there's a risk of vascular injuries, and major limitation requires an access surgeon. Lateral interbody fusions requires neuromonitoring. It's been shown that it is safe to perform the procedure going through the psoas muscle. And one of the limitations is requires multiple positioning of the patients. And one of the concerns is the lumbar plexus injuries, potential injuries. OLIF is much more similar to the ALIF, doesn't require neuromonitoring, but also has similar vascular injury risk like the ALIF procedures. And the most recently, prone lateral is being proposed, prone thoracic surgery is being performed. It's gaining quite a bit of acceptance, but we still need to learn and understand the risk and complication of each procedures. Seems like the surgeons are much more familiar doing the procedure in prone position, and the adaptation is much better for the younger surgeons than the older surgeons. They're all unique in their own. I think the key is good patient selection, choosing the right procedures, and understand the potential risk and the complications. And seems like all procedures have similar high rate of fusions. And the optimal approach depends heavily on the individual structural constraints and the pathologies on each patient. And also, training and the familiarity of the surgeons are going to be, the important factors to achieve a good results. And I finished 1 minute earlier, so you can have lunch 1 minute earlier unless you have some questions. I'm happy to answer if there's any questions. I'm happy to share I didn't want to make this talk more technical. I think if you really want to learn the techniques, we can do it in the cadavers tomorrow. There are a lot of, tips and tricks. And I really believe over my 20 years of, surgical experience, the key of the success of the surgery is the workflow. If you follow the workflow, I think the invasive and active, they prove that actually the workflow, if you follow it each steps and try not to modify them, will give you the successful results. Similarly, I think whatever the procedure you are doing it, you need to create your own workflow and follow it, and repetition will give you the better success. Thank you.
Vedat, so thanks for providing your experience with PTP. So question for you is that, I think you mentioned the disadvantages of staging with nutrition and all, but one of the advantages that, for people who has, let's say, radiculopathy, you can assess them kind of in between stages, whether your indirect decompression is enough. So with one stage, how do you make the decision whether they're gonna get enough indirect decompression, who are the ones you say, well, I'm gonna do a concurrent posterior decompression as well? I'm a big proponent of TLIF, despite everyone hating it. But one of the things that the reason I like it is because I'm looking at the nerve root. I have a pedicle to pedicle decompression, and the patient post-op is not really allowed to complain about radiculopathy from compression anyway. They can have radiculitis. So how do you decide that?
Right, so the question is like, how do you decide preoperatively to rely on indirect decompression, or when to decide to do direct decompression? So before I answer that question, in terms of TLIF, I think TLIF is a great procedure for single-level surgeries. But when it comes to a long construct and multi-level surgeries, I think it's really bloody procedure if you do 2-3 levels, and then you take significant amount of posterior elements, which is your fusion surfaces. That's why, and also, it's not as reproducible and reliable in terms of getting the segmental lordosis, or the disc preparation is not as good as the approaching anteriorly. In terms of indirect decompression, it is really a clinical decision. So if the patient comes into the clinic with radiculopathy or claudication, which changes with positioning. Let's say that patient is standing and walking gives them the radiculopathy and claudication, but the radiculopathy and claudication disappears when they are sitting or lying down. Those patients are perfect candidates for indirect decompression, because when you stabilize, when you restore the lordosis, the indirect decompression is going to work. If the patient comes in with a persistent radiculopathy, do not change with positioning, I think those are the patients that you need to be more critical about direct decompression. And there are also like people shows about the MRI, how tight it is, like the facet hooking around the nerve hooks, like they kind of make some decisions about the image guiding to make the decision. I think my decision is more about the clinical than not necessarily radiographic. So really preoperative symptoms makes me, make my decisions very easy. Like I said, if they are positional, I think indirect incorporation works with the stabilization. But if they have 24/7 radiculopathies, I think you need to be really more critical about direct decompression.
Thank you for the great talk. But I had a question regarding like the deformity patient. You do a nice large lordotic ALIF and you're doing a long construct, you're going to get the correction. Why do interbodies at 4.5 or 3.4 or above that, except for fusion? Are you seeing a lot of fusion issues with a posterior bone grafting and posterior rod construct that you need the interbody for?
So like I mentioned before, like my training was like from the beginning of my training, we were doing thoracolumbar fusion from T10 all the way down to the pelvis, anterior and posterior. And over time, actually, we moved to do more like just the L4, the S1 ALIF, and then leave the other lumbar segments alone. But if you look at some of the literature being published on deformity patients, the construct failures, actually, it's not just isolated to the 5.1. The most common construct failures is also at the thoracolumbar junction. So that is one thing. That the other part is actually that I think circumferential stabilization of the segment actually provides a little bit more rigidity of the construct. It's more likely, it's totally anecdotal. I don't think that we have large enough volume. So we looked at we published this, one of our fellows published maybe 7 years ago, looked at the lateral posterior versus posterior only approaches, and looks like there's a much more higher risk of pseudoarthrosis with the posterior approach than the circumferential fusions. There was no significant difference in terms of lumbosacral junction versus the thoracolumbar junction. I don't think that we have a high number of pseudoarthrosis or construct failures. But overall, both cohorts shown that if you do circumferential, patients are less likely to require revision surgeries than the posterior only. And the other difference was actually that the circumferential fusions did not get any CSF leaks because we were not doing any decompression. There was a significant number of patients had dural tears actually on the posterior only group because of the TLIF and the other approaches.
So thanks, Dr. Dar. So quick question about the possibility of nerve palsy. So do you think the positioning prone will be protective for the nerve roots going through the psoas as opposed to the direct lateral? Because there isn't enough numbers now.
There are some anatomical studies, MRI studies being done. When you position the patient in prone, seems like the abdominal content goes much more anteriorly. So I believe there's going to be less likely to vascular injuries in prone position. And also when the patient is in prone, initially, it's been proposed to extend the legs because the psoas and the plexus goes much more posterior. I think just keeping that neutral is actually even enough that it seems like the psoas and the plexus a little bit more posterior in prone position than the lateral decubitus position. So I think the window of access to the disc space through the psoas is much bigger in prone position than the lateral decubitus position. So we're going to see probably less neurological problems with the prone position. But one of the things that we are going to see more common in prone position, because just naturally because of the gravity, since we are talking about the complication, when they position the patient in prone, everything goes in the front and the disc space opens up. So what happens actually, the ALL is significantly stretched. So in lateral decubitus position, we were quite a bit aggressive and tried to put as large graft as possible. We were putting large trials into it to get much more disc height and much more lordotic correction. If we do the same thing on prone position, I think we are going to see much more ALL disruption. So we're going to see fish mouth opening more in prone position. So one of the things that in prone, try not to do too hard to restore the disc height, to put a larger graft, just clean up the disc and fit the cage, whatever that the cage is going to fit in that space. Try not to over-distract it.
I just want to, first of all, credit you for being such a leader in different approaches to the anterior column within our group and nationally. And second of all, it's interesting how we've evolved to all sorts of variants of how we deal with L4 to S1, but really now with understanding the distribution of lordosis, I think the consensus is an ALIF at 4-to-1 is really our best option. And I think so many MIS surgeons and so many of us have really converged to that, to really try and get 2/3 of our lordosis from 4-to-1. And I just don't think there's a great substitute for the ALIF there. And I wonder if you could just comment on
I agree. I think I totally agree. I think that's a really good point. I think in terms of planning and, deciding what to do on deformity surgeries, I think one of the things that in degenerative spine, I think we really need to pay attention about restoring the 4-to-1 lordosis. I think one of the downside of the posterior base interbody fusions, you are not getting enough lordosis in the 4-5, which leads to high risk of adjacent segment disease. I think the 4-to-1 ALIF is much powerful than any other interbody fusions.
So, Vedat, thank you for teaching me how to do an XLIF, because you are the one who taught me how to do those.
You taught me how to do a large thoracoabdominal approach too.
But you did, but anyway, we've obviously taught each other, which is one of the great things about collaboration and stuff. How do you assess who is too obese for this procedure? Because I've done a couple now, and I've really liked, having the patients prone, and that's one of the problems I always had with the single position lateral, is that I don't care what you tell me, you cannot get those patients as lordotic as you need to be, right?
No, I think, I don't know the exact answer. I think if you position the patient, if the belly is hanging outside the Jackson frame, then don't do it. That's my answer.
But then you're in the operating room, you have to plan ahead, right? So that's
it's, I really, it's kind of hard to answer because what is so we get together with the people who's doing more prone surgeries, there are a lot of surgical experience. We are trying to collect our knowledge and information, but it's a common theme. It's more difficult in obese patients if the belly is not fitting inside the Jackson frame. But in terms of the BMI, I really don't know the answer because it really depends on the height too, right? So if the patient's height and the length of the patients and the size of the belly. But it seems like it's common theme is if this outside the Jackson frame, it may not be the right thing to do.
Thanks for the talk. I was wondering, maybe I was the only one who raised my hand about reluctance to transition to prone laterals. As you mentioned, we get pretty comfortable with what we do. I think it was the same when prone single position laterals started. I think it was the same reluctance to put screws percutaneously through the lateral position, and then you do it, and you're like, oh, you just changed the way you look at things on the floor when you're placing the screws. From your experience with doing prone laterals, what changes have you noticed or made to, instead of, visualizing the spine in the lateral position, changing to the prone position? From your experience, what did you have
You
to
mean in
change?
terms of placing the screws in, or?
No, not placing screws in the interbody in the prone position.
Oh, actually, like initially, if you do a lot of lateral, it is kind of really difficult to adapt right away, because the first case is going to be a cluster, nightmare, because you are not familiar. Patient's position, just draping itself in that area is kind of like a little bit challenging, and then one of the other things is in prone position, like in lateral decubitus position, you can easily access to the psoas. I never had a patient that I haven't been able to touch the psoas with my finger. In the prone position, you can't do that, actually. It's kind of like the access is a little bit much deeper, actually. There are a lot of differences, actually. That's why I really don't want, if you go in there thinking about, okay, I'm doing the lateral surgery in prone position, you're in a totally wrong mindset. It's a completely different procedure. If you don't, take a look at it differently, because the workflow is different, what are the requirements are different. You need to, one thing is that you need to stabilize the patients, because you are, malleting the cup, the trials. If the patient is not, really stabilizing that, what happens actually that you push the spine away, the retractor comes out, and you will be cursing all day long, because you can't really do the procedure. So there are a lot of tips and tricks that you need to pay attention. In terms of visualization, after the exposure, after you put the retractor, it is pretty much the same as the lateral interbody fusion exposure. After that part, I think I really want to mention more time, don't oversize the disc spaces. I think you're going to get more ALL ruptures with the prone lateral. Wow, a lot of questions. Nobody's hungry to go eat lunch? Thank you.